big picture about buckling and the vitrectomy techniques. Invariably, as part of, as Dr. Lee mentioned, part of the vitreoretinal, part of the vitrectomy procedure is frequently the use of tamponades as part of the armamentarium that you will need to be familiar and how to manage and know the principles involved. And the tamponades that we're talking about are mainly the gases, both air as well as the long-acting gases, fluorocarbon liquids, as the synonym for PFCL, and of course our one of our frequently used tamponades of silicone oil. So I'll touch a bit on the surgical anatomy, the properties of the vitreous substitutes or the tamponades, what types are there, when to use what and how to use it, that's more important, and what are the potential complications. So in terms of the surgical anatomy, I assume all of you are very conversant in terms of the structure, the makeup of vitreous. It looks like such an unimportant part of the anatomy, but for vitreoretinal surgeons, it's probably one of the most important because it determines a lot of the outcomes and pathology that goes on within these vitreoretinal conditions. So these are the structure of vitreous and where it is most likely to be found and how to look for it. Later on, we will have techniques that will aid us in visualizing to make sure that. So while we all have the vitreous anyway, all of us, in disease states, obviously the vitreous can be removed and should be removed to prevent further further insult or complications to the retina, okay, because of this relationship. Because most of it is water and the type of collagen, as well as hyaluronic acid and chondroitin sulfate. Type 2 collagen is the most common, 70%. Okay, that accounts for the physical property of the vitreous. So it has various functions in terms of not just filling up the cavity of the eye, transparency, shock absorption, modulates inflammation and immune responses, and it's also anti-angiogenic. That's why in the normal state it keeps the eye normally vascularized. Of course, now we inject all, as you heard yesterday, as you've been talking about yesterday, in terms of anti-VEGF injections and other injections into the eye. So it is also responsible in disease states for the pathogenesis of many disorders. Of course, you know, proliferative diabetic retinopathy, in proliferative vitreoretinopathy following rheumatogenic retinal detachment because of proliferation and contraction, then secondary retinal detachment. Okay? And most of it is modulated by abnormal glial cells, and of course RPE is one of the most important factors and causing secondary fibrosis and contraction of the collagen, the type 2 collagen. But we're only talking a small part about vitreoretinal surgery applications today in terms of rheumatogenic retinal detachment. Of course, we do vitrectomy for a host of other indications as well, and a lot of times we need to use tamponades as well, not just in rheumatogenic retinal detachments. I think the history I won't go through. Dr. Lee has already alluded to the evolution of vitrectomy, and together pari passu at the same time as the developments in surgical and in modern three-port vitrectomy, the use of tamponades was also needed because we needed something to replace the vitreous that has been removed. Okay, so if you look at vitreous substitutes as a whole, in terms of broad groups, there are the aqueous miscible and the aqueous immiscible, that means it will not mix up with the aqueous. Yeah? So of course, aqueous miscible are balanced salt solution. That's what we use during the operation. Other ones are like what have been used are chondroitin, hyaluronic acid. These are without cellulose. These are miscible with aqueous. But the immiscible ones are either the gases or the liquids. The gases include the air. It's the most common gas. Air is free and is the cheapest. Sulfur hexafluoride and as a vitreous substitute, and the perfluorocarbon gases. The liquids are the lighter than water, generally, not all. They are heavier than water, silicon oil, but most of them are lighter than water, silicon oil. And heavier than water are the fluorinated silicon oils. Those add additional fluorine, makes them heavy. Fluorinated carbons. Perfluorocarbon liquids that we'll talk about, and of course the other semi-fluorinated alkanes, also used as a silicone-like substitute. So what are the ideal aqueous vitreous substitute that we would desire? Obviously, it should be an intraocular infusion fluid that is sterile and isotonic. The closest we can get to being the ideal substitute is that of VSS and VSS plus. Plus just has additional chemicals and ingredients, glutathione, glucose, magnesium, and bicarbonate buffer, as well as lactate. So common additives to this fluid is like some people would like to add glucose, 50% dextrose sometimes. Some people believe that it preserves the clarity of the lens better. And during the surgery, we use epinephrine to aid in hemostasis and control of the hemorrhage. Okay. So intraocular gases per se has been in use as a treatment of retinal detachment as early as 1911 and was first used by Ohm. It was, however, not Rosengren who later formed the concept of intraocular tamponade by air because of the buoyancy. And in the 1950s, Norton, Linkoff, and others used air and other gases in the treatment of giant retinal tears and other complex retinal detachments. So they just use it as an injection into the eye. Okay. In the 1970s, SF6 became found to be a useful short to medium acting gas for difficult retinal detachments. It was in the 1980s that the longer acting gases were found and to be suitable, and these are the perfluorocarbon gases. And that's around the time when pneumatic retinopexy was touted as an alternative to skull buckling in the treatment of retinal detachment, okay, just by injecting a bubble of a gas into the eye. So the properties of intraocular gases, obviously they need to be inert, they have to be colorless and odorless for the safety of the users. It should be non-toxic, obviously, to the retina and the other tissues. It should be water soluble because it needs to be diffused out of the eye, and the solubility varies with the type of gas, and obviously the lower the solubility, the longer acting will be the gas, and the longer will be the intraocular longevity. So it will stay longer for the period. So what is the functional role of the gas bubble? Obviously, because of its surface tension properties, it creates a gas fluid interface which is effectively can seal the retinal breaks. Obviously, all gases are buoyant, so a buoyant force is because it has lower specific gravity than water, so it will float, it will rise. And the force of this buoyancy can be measured and compared, and it is generally, we know that the gas exerts a much more buoyant force than compared to, say, silicon oil. and up to 10 times. So you would think that silicone oil is like a viscous fluid, that it can exert a lot of buoyant force if you place it against the tissue, but actually it doesn't. Gas is has much more buoyant force compared to silicone oil. And using gas allows us to perform postoperative fluid gas exchange. That allows us to prolong the intraocular tamponade. But if you can add additional gas into the eye in situations where it's needed, it can also help to clear out whatever vitreous fluid that is blood stained or contains a lot of cells and other pigments in the vitreous fluid after vitrectomy. And you can easily, in a well-filled eye, perform postoperative laser using the wide-angle lenses and learning the technique. So you can even perform laser through the gas. So the physical properties, obviously the surface tension is the most important. If you look at air or gas, exerts the surface tension force much more than silicone oil, as I mentioned. So the force of the tamponade is pari passu because it has more buoyant force, has more surface tension. So comparatively, gas has the highest compared to other to the silicone oil. Okay, so tamponade force. So what factors affect the rate of gas transfer? And obviously the size of the bubble, the bigger it is, it takes longer. The coefficient of the diffusion coefficient in tissue, the thickness of the area, solubility, the flow rate, the blood flow, because you need the blood to diffuse, the gas to diffuse into the ocular blood, and the contractions of the vitreous fluid. So there are two types of gases that can be used. So there are the non-expanding gases as well as the expanding. Basically, as far as non-expanding, most of us just rely on air. It's difficult to get the other gases in a pure state to be used in the eye, but commercially available expanding gases are definitely available, and there are only two classes: sulfur hexafluoride or the perfluorocarbon gases, of which either perfluoroethane and perfluoropropane are probably the two most available commercially for eye use. So basically this summarizes the type of gas, how long it takes to reach the maximum bubble size, what is the half-life absorption, what is the concentration that you need to use and know so that you do not cause a dramatic increase in intraocular pressure. Yeah? So the non-expansile concentration is very important. And that dwell time, that means the therapeutic volume, when it reaches the maximum size that you can use, that will have its maximum effect in terms of the, for example, in cases of pneumatic retinopexy. So this is comparing between sulfur hexafluoride, perfluoropropane, because air and perfluoroethane. Okay? The rest are usually not used. So very simple chart to explain the expanded volume. Sulfur hexafluoride will expand to 2 times its initial size or volume. Whereas if we use any of the perfluorocarbon gases, it expands between 3 to 4 times. If you look at C2F6, which is perfluoroethane, it expands about 3 times. And C2F6, so we're talking about the pure volumes of these gases. So if you inject 1 cc, it will expand to 2 cc's in the eye. And disappearance time in the patient's eyes, of course, the perfluorocarbon gases last a long time, depending on the type. C2F6 roughly about a month, C3F8 about 6 to 8 weeks before it finally disappears completely in the patient's eye. So gases provide longer internal tamponade compared to just air, and it is used in many primary uncomplicated retinal detachments after vitrectomy, and the longer ones are used for more difficult detachments like giant retinal tears, and also in cases of PVR. So it is also used as a non-buckling treatment of suitable non-complicated superior retinal detachments, for example in pneumoretinopexy. Okay, and of course, because nowadays we do macular surgery, it is also useful to treat select retinal conditions, for example, macular holes. We need to put gas to seal, to close the holes as well. So the dynamics is very important. It goes through bubble expansion, then nitrogen then equilibrates, and then it dissolves out of the eye. Okay, so it expands purely because gas diffuses into the bubble when it is less soluble than nitrogen, and usually the most rapid rise, increase of this diffusion of gas is in the first 6 to 8 hours after injection. So when nitrogen, oxygen, and other gases diffuse into the bubble. All right. So it reaches an equilibrium when the partial pressures of the nitrogen is equal to the surrounding tissue. Then you get a stable state of diffusion, and the bubble reaches its maximum size. So depending on the type of gas, it will take either 1 day or 2 days or 3 days, something. Yeah. So then after that, all gases will diffuse out of the bubble, and there will be a sequential decrease in the size of the bubble of the exponential decay, an exponential fashion. So maximum for inhalational general anesthesia, if you use nitrous oxide, there might be rapid nitrogen that goes into the gas bubble, right? So if there's a continuous inhalation of nitrous oxide, you might end up with a much smaller bubble at the end of surgery. So we always avoid nitrogen or nitrous oxide general anesthesia to tell you anesthesia. So expanding gases are less soluble than nitrogen and water and will expand, right? As I mentioned, so the maximum expansion for SF6 is between 24 to 48 hours, and C3F8 is between 72 to 96 hours. So that will give you the time frame that you need to monitor the patient in terms of the intraocular pressure. It was mentioned earlier about the air travel. So rapid decompression of the atmospheric pressure may cause a dramatic elevation of the IOP due to an increase in the size of the bubble in patients with a moderately large bubble. Okay? And this happens usually during the ascent of the aeroplane, and then it stays in that state until the chamber is decompressed again. Although some people feel that less than 1 cc of gas is safe for air travel, there are some other studies that advocate zero gas tolerance. That means you have to wait for the entire bubble to dissolve before you allow the patients. Because the potential problem in using gases is raised intraocular pressure, and because through various reasons there might be when you're using pure gases. So to avoid that, when you're using pure gases, so the volume must not be large so that you don't occupy too much of the vitreous volume. And also take note, as I mentioned, during air travel, to prevent to inform the patients that they are unable to fly. So these are the intraocular uses, the clinical uses of intraocular gases. I mentioned pneumoretinopexy. We talked about fish mouthing in scleral buckling. Using gas is very useful to treat that secondary problem, that folds in the retina. You can use gas to smoothen them out. You can use gas to restore the intraocular pressure after subretinal fluid drainage. Of course, if you do vitrectomy in complicated detachments, you will use the gas. I won't talk too much about pneumoretinopexy. It is still sometimes practiced, but usually only in North America as a office type procedure where patients are not needed to be admitted into can be performed in the clinic. But there are many studies have shown that the overall reattachment rate is much lower than scalp buckling. So, which gases to use? So, in a non-vitrectomized eye, you would probably only stick to air, xenon, or SF6. In pneumoretinopexy, which is again a non-vitrectomized eye, some people advocate longer so that the peripheral carbon gases, so that you achieve a much larger size of the bubble. Okay. In vitrectomized eyes, you would use the medium or the long-acting, and of course in complicated retinal detachments, most likely you will use the peripheral carbon liquid gases. Okay. So you must know the non-expanding concentrations of sulfur hexafluoride, C2F6 and C3F8, and so that you can dilute the gas accordingly. So there are technical difficulties with using gases, either intraoperatively or postoperatively. Intraoperatively, obviously, sometimes when you inject the bubble in the eye during scleral buckling, it makes the retinal view difficult. So you have to know how to overcome the view through a bubble. Of course, preparation, and the assistant or the nurse, and even up to now, I dilute the gas myself. You never allow your assistant or your nurse to determine the concentration. They will give me the pure gas, and I will dilute it myself, so that to avoid having a wrong concentration injected into the vitreous cavity. Postoperatively, of course, I mentioned about intraocular pressure and the need for posture in a lot of these patients with who are phakic, and also to tamponade the retinal brain. Okay? So posture, if you want to check eye pressure, usually in the first 6 to 8 hours because of the maximum expansion, and if there's excessive filling, you must be very quick and prepared to just quickly decompress the eye by paracentesis, or even in doing a vitreous injection to relieve the gas. So those are the post-operative problems you can use. It's useful as a post-operative fluid gas exchange because sometimes you need to increase the size of the bubble. Sometimes there's blood and debris and fluid within the vitreous cavity. You can do a post-operative fluid gas exchange. For example, there's a secondary detachment, and you still think that additional laser, by just adding more gas and laser, it might be able to relieve the detachment. But in these cases, always use non-expanding volumes. And you can do this in the outpatient clinic setting, so that you can, obviously fluid air exchange is done intraoperatively during the vitrectomy procedure, and you can either do air gas exchange, or some people do air silicone oil exchange. So this technique was, of course, first described by Dr. Steve Charles, and just using very principles of pressure and venting, so that you use pressure to push the fluid out of the eye through a needle. Okay. In terms of post-op exchange, you can do this in the clinic, in the supine or lateral position, okay, so that you can remove the fluid and re-inject more gas into the eye. Okay. So we mentioned about these complications. As far as silicone oil is concerned, I think it's been used since the 1950s, proposed as a vitreous substitute. But it was not in the 60s, it was popular, but not until Ando described inferior PI, because using it in an aphakic state resulted in a lot of secondary glaucoma and secondary complications. So the inferior PI was described as a means to keep the silicone oil behind the pupil, allowing the fluid to come through. Okay, the inferior iridectomy. So there are lighter than water or heavier than water silicone oils, and obviously you can the lighter than water are usually 1 or 5,000 or 1,003 or 5,000 centistokes. The heavier than water silicone oils, initially popular mostly in Europe, not much used here in Asia. Some people still, but these are the oxane or the densiron or F6H8. These are because they have a downward tamponade force, much greater than the lighter than water oils, standard silicone oils. This is a chemical structure if you are interested, but the action is both hydrophobic and hydrophilic, and may interact with cell membranes and tissues, and may contain pro-inflammatory factors and may cause cellular adherence. So some people think that actually it makes it worsens PVR in cases of retinal detachments because of it causes inflammation. There is a difference if you use it in terms of the refractive properties, so you always have to tell your patients the refraction will change. Usually there is a hypermetropic shift between, on the average, between 5 or 7 diopters. But again, that depends a lot on the refractive state of the eye itself. In very myopic eyes, sometimes there is not much of a shift. And between phakic and aphakic eyes is also different. So you have to take into account that. Obviously, it's more used in complicated retinal detachments where you're not sure of the state of the retina. You know that gas, when the gas disappears, the retina might redetach very quickly. So silicone oil buys you time in a lot of these complicated detachments where repeated surgeries may be needed. So I find it useful in cases where I think more than one surgery may be needed, so that you use it and it can buy you some time, so you don't have a rapid, you don't have to go in quickly. Once the gas dissolves, you have to reoperate. But having said that, there are definitely complications with using silicone oil. Foremost of which is that if it's a phakic eye, it will almost for sure induce cataract formation, secondary glaucoma, rise in intraocular pressure. If it's an aphakic eye and the silicone oil comes into the anterior chamber, it will cause keratopathy. Even left on its own, naturally, it will emulsify and it will migrate into the anterior chamber. And it has been also reported to cause hypotony, but usually because of the primary retinal condition, it's already very severe. I could finish up on peripheral carbon liquids, and I think when we talk about peripheral carbon liquids, it was discovered mainly as a vitreous substitute and reported and then first used by Stanley Chang, those who know him. Read all the early papers about peripheral carbon liquids and how it's used in the treatment of giant retinal tears, and that really revolutionized the treatment of giant retinal tears because of peripheral carbon liquids. Because in the past, the results of GRT repair was very poor until peripheral carbon liquids. All right, there are a few that have been used, but again, now commercially it is probably down to only 2. One is peripheral N-octane and peripheral decaline. Okay, so there are two of these are the more common, are the ones that are commercially available now. And the main property that you need to look for is the specific gravity, because that is much greater than water, so that it exerts a tamponade force on the retina, and the fluid gets displaced by peripheral carbonates, okay, liquids. And of course, the refractive index is very close to aqueous, so that it is like a transparent and causes no distortion, and a very low viscosity, so that it's easily introduced and removed at the end of surgery. So it's not it's a tamponade, but you don't leave it. Of course, there are people who have used it as a very short-acting tamponade postoperatively. You read the papers from Sydney, and certain they use it for inferior detachments, for giant retinal tears, so they leave it in for 1 week, and after a week, they go in, operate, and then remove the heavy liquid again. Okay. So as I mentioned, the most important property is that of high specific gravity of 1.7 to 2 compared to water, and low viscosity of 0.8 to 8 centistokes, so it's practically water, so that you can use it to you can see it very clearly during surgery, and you can put it up to where you want, usually up to the edge or beyond once you have completed the vitrectomy. And through it, you can see very clearly that you can perform laser photocoagulation to the edges of the retinal tear, as you have seen earlier. And because it has a great tamponade force, it will keep the retina attached, and much greater than silicone oil. So it's used, as I mentioned, mostly by us as an intraoperative tool for surgical manipulation of the retina to displace blood, control bleeding, and in certain conditions where you might use it to retrieve intraocular lenses or intraocular lens implants. As a post-op tamponade, as a temporary tamponade of inferior retinal detachments and giant retinal tears, used by some. Obviously, it is used in complicated, but nowadays because it's so widely available, even in some people use it routinely in all vitrectomy cases of retinal detachments, but generally reserved for more complicated cases of like giant retinal tears. PVR is very helpful to stabilize the posterior retina. In diabetic retinal vitrectomies as well, when there's traction, you can use it to identify planes so that you move. But there are complications if you don't use it properly. You can have retained peripheral carbon liquids as well as subretinal peripheral carbon liquids. So you need to be properly to be familiar with how to use it and how to remove it from the eye completely. Because if you leave it in the eye, it is actually been shown to be toxic to the photoreceptors. So this is the principle where you use it to treat retinal detachments, and some people use it to help in retrieving intraocular lenses or intraocular lens implants during vitrectomy. So all these tamponades are definitely useful adjuncts in vitreoretinal surgery. We have it at our disposal, at our disposal, so that we can perform safe surgery. We may not be ideal because they may have toxicity issues because of inflammation and cellular proliferation and toxicity to the retina and other ocular structures. All right, thank you very much. Okay, I think we should press on with Dr. Nathuwat. We can have questions at the end if there's more time, there's still time. It's my pleasure to invite Dr. Nathuwat Rodanan from Bangkok. He's an excellent teacher, so he's here to talk about the principles of vitrectomy, the pitfalls and pearls, as well as continue on with talking about specifically micro-incision vitrectomy surgery. And I've given him 1 hour or more, as long as he wants, for this part. Thank you.